We are going to now hear from Dr. Deborah Richardson, who is also at the Stevenson Cancer Center in Oklahoma, where she's an associate professor in the Division of GYN Oncology. And Dr. Richards is going to talk to us about another category of drug development, which has really resulted in a lot of new approvals lately, especially one for ovarian cancer. And these are antibody drug conjugates and immunotherapies. You guys probably have figured it out already. That was a little over. We're in general going to be about 17 minutes over for session one. So that's going to cut into some of the in between activities. So they'll be shortened slightly. However, sessions 2, 3, and 4 are going to run about 5 minutes under. So the entire day is going to balance out. And I'm talking fast to try to shorten my part. So with that, I will click back off and we will hear from Dr. Richardson. I will tell you one other thing, which is that don't forget to put your questions in the Q&A. We're not answering them now, but during the discussion, Dr. Matalonis, who you see down there, who is the head of GYN Oncology at the Dana-Farber Cancer Institute and also a professor at Harvard Medical School, is going to take us through the Q&A with these two great presenters, and we will be able to ask questions at that time. Thank you.
Hello, I'm Debbie Richardson. Thank you for inviting me to present to you today on the latest and greatest antibody drug conjugates, immunotherapy, and combined targeted agents. I am at the Stevenson Cancer Center, University of Oklahoma Health Sciences Center. So this is an antibody drug conjugate. It's made up of 3 parts: an antibody, a drug, and the linker. The antibody is a highly selective antibody for a tumor-associated antigen that has restricted expression on normal cells. It then has a linker that is stable in circulation and a potent cytotoxic agent that's designed to induce target cell death when internalized. And this is a picture showing this. I kind of like to think of antibody drug conjugates as smart bombs, where they are targeted to the tumor cell. The tumor cell then takes it up and then it gets inside the cell and is degraded in the endosome lysosome pathway and digested by proteases, which then releases the toxin, leading to cell death. And this is tisotumab vedotin, an antibody drug conjugate that targets tissue factor. That's a common thing overexpressed on cervical cancer as well as some other types of tumors. And as you can see, there are multiple different ways that tisotumab can result in cell death, including direct cytotoxicity, can also lead to bystander killing, and that means killing the tissues along in vicinity of the tumor cell that took it up. It can have immunogenic cell death. There can also be antibody-dependent cellular cytotoxicity and antibody-dependent cellular phagocytosis. And this was a trial innovative 204 GOG 3023. This was a phase 2 single-arm multi-center trial in both the United States and Europe, and enrolled women who had recurrent or extrapelvic metastatic cervical cancer who had progressed during or after doublet chemotherapy with bevacizumab if they were eligible for bevacizumab. And they could have received up to 2 prior systemic regimens. The ECOG performance status was 0 to 1, and the patients received tisotumab 2 milligrams per kilogram IV every 3 weeks. And this was continued until progression or unacceptable toxicity. Tumor responses were done via imaging every 6 weeks for the first 30 weeks and then every 12 weeks thereafter. The primary endpoint was objective response rate per RECIST, and it was assessed by an independent review committee. And as you can see, there were multiple different secondary endpoints. And these are the baseline characteristics of the patients enrolled in this trial. As you can see, it's as expected for recurrent cervix cancer population. The majority of patients had squamous cell carcinoma. About 2/3 had had prior bevacizumab, and almost all the patients, 96%, were positive for tissue factor. And this was the response rates. As you can see, it's a pretty impressive 24% response rate and 7% complete response. And additionally, the disease control rate was 72%. The median duration of response was 8.3 months. And this is the progression-free survival, which was 4.2 months for median, and 34% of patients were progression-free at 6 months. On the right of this screen is overall survival, where the median overall survival was 12 months and 79% of the patients were still alive at 6 months. This is the side effects that were seen most commonly with at least a 10 greater than or equal to 10% incidence. As you can see, in the teal color was grade 1 or 2, and in the darker black color was grade 3 and above. The majority of patients did have toxicities on this. The most common was actually alopecia at 38%. The next most common was epistaxis, and the majority of those were nosebleeds. There's also nausea. We saw conjunctivitis, fatigue, dry eyes, myalgias. The majority of these side effects, as you can see, were grade 1 or 2. There was one death due to septic shock, which was considered by the investigator to be related to therapy. And there were 3 pre-specified adverse events of interest: ocular, because of the cytotoxic agent in this antibody drug conjugate, same for peripheral neuropathy, and bleeding because of its target of tissue factor. And as you can see, the darker color is grade 1, the lighter blue is grade 2, and the dark color is grade 3. Majority of these events were grade 1 and 2, and most of them resolved, at least the ocular and bleeding. The risk of ocular AEs may have been reduced with the implementation of an eye care plan, which we're going to go over in a moment. And the peripheral neuropathy events were manageable with the majority grade 1. As you can see, the median time to onset for ocular was about 1.4 months, bleeding 0.3 months, and peripheral neuropathy 3.1 months. Again, 86% of the ocular events had resolved and 90% of the bleeding. Peripheral neuropathy, however, tended to be more permanent. And this is the recommended eye care. There's a nice website that you can go to that goes over the recommended eye care for using tisotumab. There is a black box warning on this drug that patients do need to see an eye care provider prior to initiating treatment with tisotumab, and then every cycle. Patients need to undergo a baseline eye exam with visual acuity, slit lamp exam, and Schirmer's test, which evaluates if a person's eye produces enough tears to keep their eyes moist and healthy. They should then use preservative lubricating eye drops daily, steroid eye drops, TID cycles day 1 through 3, and 3 drops of vasoconstrictor eye drops in each eye prior to infusion. And finally, ice packs should be placed on the eyes during the infusion and for 20 minutes after the infusion is completed, and patients should avoid contact lenses during treatment with tisotumab. So excitingly, the FDA did grant accelerated approval to tisotumab for recurrent or metastatic cervical cancer on September 20th, 2021. Next, we're going to switch gears a little bit. So now we're going to target the folate receptor alpha, which is commonly overexpressed on the surface of ovarian cancer. It mediates folate transport into epithelial cells. It can also be upregulated on other cancers, including endometrial and triple-negative breast cancer. It is most highly expressed on the surface of serous epithelial ovarian cancer. And as you can see in the diagram, on the left is 1+ intensity, in the middle is 2+ intensity, and on the right is 3+ intensity, quite dark staining. So this is a depiction of mirvetuximab. Again, it has a high affinity binding to folate receptor alpha and is internalized efficiently. Its payload is a maytansinoid known as DM4, and this is a potent tubulin targeting agent. Its drug antibody ratio is about 3.4 to 1, and the linker is stable in circulation. This was the Forward 1 trial. This was a randomized phase 3 trial of women with platinum-resistant ovarian cancer who were positive for folate receptor alpha with either medium, which is defined as 50 to 74% cells positive, or high at greater than or equal to 75% cells positive. ECOG performance status of 0 to 1, and they could have 1 to 3 prior therapies. They were randomized 2 to 1 to either mirvetuximab or investigator's choice chemo with either weekly paclitaxel, PLD, or liposomal doxorubicin, or topotecan. And the primary endpoint for this was progression-free survival by blinded independent review committee for the intention to treat population, and then also the high folate receptor alpha populations. And to point out, because of this, they did use a correction called the Hochberg procedure, which we'll talk about in a little bit when we go over the results. It was two-sided alpha of 0.05. And this was the baseline characteristics. The majority of patients had ovarian cancer, high-grade serous. About almost 50% had had prior bevacizumab, and about 42% were medium folate. This was the safety data. As you can see, mirvetuximab is in the blue and chemotherapy is in the pink, and the darker is high-grade toxicity. On the left is your hematologic toxicity, and chemotherapy caused much more hematologic toxicity than mirvetuximab is associated with. There was some peripheral neuropathy with mirvetuximab, though not as much as with weekly paclitaxel. If you look at towards the right, ocular side effects are much more common with mirvetuximab, including blurred vision, keratopathy, and dry eyes, but most of these are low grade. And on the left of this is the intention to treat population. On the right is the folate receptor alpha high population. As you can see, the PFS was not different in the patients intention to treat who receive mirvetuximab versus chemotherapy. However, I'll draw your attention to the right in the folate receptor alpha high population, where the hazard ratio was 0.69 for those patients who had mirvetuximab compared to chemotherapy. The median progression-free survival of 4.8 months versus 3.3 months. The response rate was 24% compared to 10%, and the hazard ratio was 0.7. This p-value for the progression-free survival was less than 0.05. However, because of the Hochberg progression, they actually needed to have less than 0.025 to be statistically significant. However, this did give us good baseline data to be able to design future trials. And so that leads us to the SORAYA trial, which was a single-arm pivotal trial for mirvetuximab using the PS2 plus scoring in the folate receptor alpha high platinum-resistant ovarian cancer. And it should be pointed out that in the previous trial, they had changed how they scored the folate receptor. And so for this trial, they went back to the original PS2, which is a little bit more complicated, but seems to be better predictive of response. And this was presented by Dr. Machulonis at SGO last year. The primary endpoint was overall response rate. The plan was to enroll about 100 patients with platinum-resistant disease with a primary progression-free survival of at least 3 months. Prior bevacizumab was required, and prior PARP inhibitors were allowed. Patients with BRCA mutations were also allowed. This was the baseline demographics. Again, the majority of patients had epithelial ovarian cancer. About 20% had BRCA mutations. And I will draw your attention that this was a relatively heavily pretreated group with 51% having 3 lines of treatment previously. Again, bevacizumab was required, so 100% of patients had had that, and almost 50% had had prior PARP inhibitors. These were the investigators assessed objective response. On the left is the overall population, and as you can see, the response rate was quite impressive at 32%, and it really didn't vary when we broke it into subgroups. So if you compared 1 to 2 lines versus 3 lines, it was fairly similar at 35.3 versus 30%, and for prior exposure to PARP inhibitors, 38% versus 27.5%. And this is the swimmer's plot. In general, patients responded by the first or second scan. That's denoted by the black dots. And you can see that the pink represents complete response and the blue is partial response. The median duration of response was a respectable 6.9 months. For treatment-related adverse events, most adverse events were low-grade, reversible ocular and GI events. Serious grade greater than or equal to 3 treatment-related adverse events were reported in 8% of patients. Treatment-related adverse events led to dose delay in 32% and dose reduction in 19%. 7 patients discontinued treatment due to treatment-related AEs. 1 death was recorded as possibly related to study drug, which was respiratory failure. However, on autopsy, there was no evidence of drug reaction, and the patient did have lung metastasis. There was only 1 grade 3 neutropenia. And again, this antibody drug conjugate also has some ocular toxicity similar to tisotumab, though they are a bit different in how they present. About 47% of patients did experience ocular toxicity. There again is a mitigation strategy or an eye care plan, which includes lubricating artificial tears and corticosteroid eye drops. It's very predictable. It typically happens right in the middle of cycle 2, about 1.5 months after starting drug. It is manageable with dose modifications if that's needed. 22% of patients did require dose delay and or reduction. It is reversible. At the time of data cutoff, more than 80% of patients with grade 2 or 3 events had resolved to grade 0 to 1. And one of 106 patients discontinued due to grade 4 keratopathy. However, that keratopathy resolved within 15 days. And this is similar, but a little bit different than tisotumab as far as the eye care. Again, patients do, it has a black box warning on it. There needs to be a baseline eye exam by an eye care provider, again, assessing for visual acuity and a slit lamp exam. And this is done every other cycle for the first 8 cycles and then as needed. Patients should use preservative-free lubricating eye drops 4 times daily at about 10 minutes after the steroid eye drops. And steroid eye drops should be done 6 times a day for cycle day 1 to cycle day 4, and then 4 times a day from cycle day 5 to 8. And again, contact lenses should be avoided. So another exciting thing, the FDA did accelerate approval of mirvetuximab for folate receptor alpha positive platinum-resistant epithelial ovarian fallopian tube or peritoneal cancer. It does require a companion diagnostic test, and patients need to have high FOLR1 expression. And the confirmatory trial was the MIRASOL trial. This is a phase 3 randomized trial for mirvetuximab in folate receptor alpha high patients with platinum-resistant ovarian cancer. It has completed enrollment, and we do expect results soon. Patients were randomized to either mirvetuximab or investigator's choice chemotherapy with either, again, weekly paclitaxel, PLD, or topotecan. And again, the primary endpoint was PFS by investigator with a blinded independent review for sensitivity analysis. 430 patients were planned to be enrolled. They could have 1 to 3 prior lines of therapy. Again, they had to have a platinum-free interval of greater than 3 months. Prior bevacizumab and prior PARP inhibitor was allowed. And again, patients with BRCA mutations were allowed. This is a little bit different because it did not require bevacizumab like Soraya did. And next, we're going to talk about a different target called NaPi2b, which is a sodium-dependent phosphate transporter. So this is upifitamab rilsodotin, or UpRi for short. This antibody drug conjugate uses a payload known as auristatin F-HPA, and it has a very high drug to antibody ratio of about 10. You'll remember for mirvetuximab, it's about 3.5. And this allows it to be taken up and then it gets locked to control bystander effect. NaPi2b is expressed by tumor cells in about 2/3 of patients with high-grade serous ovarian cancer, and it is a lineage antigen. It is not an oncogene. And this was studied in a phase 1b study known as the expansion cohort study. Patients that were enrolled in this had 1 to 3 prior lines in platinum-resistant setting, or they could have 4 prior lines regardless of their platinum status. High-grade serous histology, they had to provide tumor either archived or fresh biopsy, and patients with primary platinum refractory disease were not allowed. They were received UpRi IV every 4 weeks until disease progression or unacceptable toxicity. There were 2 different dose cohorts. One was 36 milligram per meter squared, which was started in August of 2019. And then there was a 43 milligram per meter squared, which was the maximum tolerated dose, to a max of about 80 milligram cohort initiated in December of 2019. The primary objective was to evaluate the safety and tolerability of the maximum tolerated dose or the recommended phase 2 dose, and also to assess preliminary efficacy. On the left is the dose group 36. On the right in purple is the higher dose at 43. You can see that there was no severe ocular toxicity, neutropenia, or peripheral neuropathy in either dose group. 14% of patients did have a treatment-related SAE in dose group 36 compared to 27% in dose group 43. And you can see in general the higher grade toxicities were less common with the lower dose. There was also lower frequency and lower grade pneumonitis in dose group 36 with no grade 3 or higher compared to dose group 43. And this is our waterfall plot showing response. As you can notice, 67% of patients did have a target lesion reduction from baseline. And I'll draw your attention that the 2 patients who did have CR actually were treated at the lower dose of 36 milligram per meter squared. And this was the confirmed overall response rate. Overall for high NaPi2b, which is defined as a tumor proportion score of greater than or equal to 75, the overall response rate was 34%. It was actually higher in the dose group 36 at 44% compared to 27% in the dose group 43. In addition, the median duration of response in patients with the NaPi2b high ovarian cancer was about 5 months. And this was a Uplift, which has completed enrollment. This was known as GOG 3048. This is a registrational trial enrolling patients with platinum-resistant ovarian cancer, 1 to 4 prior lines of therapy. And if they only had 1 to 2 prior lines, they had to have prior bevacizumab. Patients received UpRi at 36 milligram per meter squared, up to a max dose of 80 milligrams IV every 4 weeks. The primary endpoint was confirmed overall response rate in the NaPi2b high with hope for about 100 patients. And then we don't have the results for that yet, but Up Next has started enrolling. This is going to be the confirmatory trial. This is GOG 3049. This is enrolling platinum-sensitive recurrent high-grade serous ovarian cancer who have had 2 to 4 prior lines of platinum-containing chemotherapy. And patients can come on if they are no evidence of disease, complete response, partial response, or even stable disease. Patients do have to be NaPi2b high, and if they have a BRCA mutation, they have to have had prior PARP inhibitor. Patients are going to be randomized 2 to 1 to either UpRi at 30 milligram per meter squared or placebo every 4 weeks with a primary outcome of progression-free survival. We're going to now switch gears again to immunotherapy and combined targeted therapy. So Keynote 158 was looking at pembrolizumab, which is an anti-PD-1 in patients with non-colorectal mismatch repair deficient cancer. And the patients had to have had progression or intolerance to prior standard therapy. And the majority of the patients did have more than 2 lines of prior therapy. In fact, a third had greater than or equal to 3 prior lines of therapy. As you can see, for the endometrial patients, there was a very high response rate at 57%. The median progression-free survival was 25 months, and the median overall survival was not reached. This led the FDA to approve pembrolizumab for patients with dMMR metastatic tumors, including uterine cancer. Next is the Garnet trial. This investigated another anti-PD-1 known as dostarlimab. This was a phase 1 trial. Patients received dostarlimab at 500 milligrams every 3 weeks for 4 cycles, and then was switched to 1,000 milligrams every 6 weeks. This had 2 cohorts. The orange is the dMMR or microsatellite unstable patients, and the blue line is the patients who are proficient in mismatch repair or microsatellite stable. As you can see, the overall response rate in the MSI high or mismatch repair deficient patients was 45%. It's 15% in the microsatellite stable group. And there was an impressive 16% of patients who did receive a complete response to dostarlimab. On the top is the progression-free survival curve with a median PFS of 6 months. And on the bottom is overall survival, which was the median overall survival was not reached. And that led the FDA to approve dostarlimab as well in the setting of mismatch repair deficient or MSI high recurrent endometrial cancer. So we also know that patients can have, treatment resistance. And so we're trying to figure out good combinations of drugs. That can mean using drugs that target the cancer's ability to make new blood vessels, angiogenesis. It can mean targeting drug efflux pumps. It can mean targeting the cell cycle with drugs that, for example, CHEK1/2 inhibitors or WEE1 inhibitors. We can use hypomethylating agents to affect epigenetic changes. We can try and target alterations in DNA response by using things like PARP inhibitors, ATR inhibitors, we can enhance immune responses, and we can do metabolic reprogramming as well. So that's how we got to Keynote 775. This was a trial taking patients with recurrent advanced or metastatic uterine cancer with measurable disease, and they were randomized to either lenvatinib, which is a multi-target kinase inhibitor that's given orally with IV pembrolizumab, the anti-PD-1, or physician choice of one of two chemotherapies, either doxorubicin or weekly paclitaxel. And the primary endpoint was of primary progression-free survival and overall survival. And this is the most recent data presented by Dr. Macker. This is a progression-free survival by histology in patients who are mismatch repair proficient. On the left is endometrioid, and that was the majority of the patients. The median progression-free survival for patients who received lenvatinib and pembrolizumab was 7.6 months compared to 5 months for those who got chemotherapy. Serous, again, still improved with a hazard ratio of 0.54, median progression-free survival of 5.7 months compared to 3.6 months. And patients also benefited from clear cell, median PFS of 3.9 months compared to 2 months. And the FDA did approve lenvatinib and pembrolizumab for recurrent uterine cancer for second line for patients who are mismatch repair proficient. And we do know there's also an overall survival benefit of lenvatinib plus pembrolizumab. The median overall survival for len-pem was 18 months compared to chemotherapy 12.2 months in the proficient group. And this is despite the fact that almost 10% of patients who had received chemotherapy went on to get lenvatinib and pembrolizumab. It's possible that immunotherapy is going to move up earlier in lines of treatment for uterine cancer. So there are multiple ongoing trials. I'm not going to get into the details of this, but you can see immune checkpoint inhibitors are being looked at to be combined with chemotherapy. And in one of the trials, DUO-E, they're also looking at adding PARP inhibitor as maintenance in addition to immune checkpoint inhibitor. So stay tuned as to these results. Hopefully we will start seeing some of these results in the next year. And then what about alternative strategies for mismatch repair proficient or microsatellite stable endometrial cancer or after patients have had immunotherapy? Well, there's been a couple of trials to help inform this. GOG 3007 looked at everolimus, which is an mTOR inhibitor, with letrozole, which is an aromatase inhibitor, compared to alternating tamoxifen and medroxyprogesterone acetate. And they found a higher response rate, about 53% in the everolimus letrozole group compared to 43% in the medroxyprogesterone tamoxifen group. On the right is paleo, again, similar setup. However, this was letrozole and placebo compared to palbociclib, which is an anti-CD4/6 inhibitor used a lot of times for breast cancer, and letrozole. And the disease control rate was higher in the combination of 63% compared to 37% in letrozole alone. And the median progression-free survival was 5 months better in the palbo combo arm compared to letrozole alone. One more immunotherapy that we can use now for gynecologic cancers is based on Keynote 826. This was for recurrent or metastatic cervical cancer. Patients received pembrolizumab, 200 milligrams IV every 3 weeks with paclitaxel and platinum, plus or minus bevacizumab, compared to no placebo rather than pembrolizumab. And this is the baseline characteristics. As you can see, for the CPS score, the majority of patients had a CPS score of at least 1. And here is the initial stages at diagnosis. It was fairly well balanced. And additionally, about 2/3 of the patients did receive bevacizumab with this regimen. These was the dual primary endpoints. The progression-free survival and overall survival were both improved in the arms where pembrolizumab was added. It was a median progression-free survival of 10.4 months compared to 8.2 months, and for overall survival, 24.4 months compared to 16.5 months. And this led the FDA to approve the addition of pembrolizumab to platinum-based chemotherapy plus or minus bevacizumab for patients who have at least a CPS score greater than or equal to 1 for recurrent cervix cancer. I'm not going to get into the weeds of this, but just to show you that there are many different biomarker-directed targets for ovarian and uterine cancer currently in phase 2 and 3 trials. And so the next time you get this update, there will be likely new medications to talk about, which is very exciting. So in conclusion, there are 2 FDA-approved antibody drug conjugates now for recurrent gynecologic cancer, tisotumab, which targets tissue factor for cervical cancer, and mirvetuximab for folate receptor 1 positive platinum-resistant ovarian cancer. For immunotherapy, we have pembrolizumab or dostarlimab for MSI-high or DMMR recurrent endometrial cancer. For patients who are MS stable or mismatch repair proficient, we have the combination of lenvatinib and pembrolizumab for recurrent uterine cancer. For metastatic or recurrent cervix cancer with the CPS score of greater than or equal to 1, we now give pembrolizumab in addition to platinum-based chemotherapy with or without bevacizumab. And there are many trials of targeted agents ongoing. Thank you so much.